Hi everyone, I want to talk about advanced cardiac life support. Advanced cardiac life support. It means there must be basic life support. I will make a separate presentation on that another time. But for now, as far as advanced cardiac life support is concerned, let's go. Advanced cardiac life support will be needed in any emergency situation or in most emergency situations. Could be needed if there's road traffic accident, fall, choking and can't talk anymore, heart attack, or severe acute asthmatic attack, arrhythmia, and the individual has become unresponsive. In other words, emergency situation could lead to unresponsiveness. Road traffic accident could present in such a way that many people will become unresponsive. Somebody has fallen down from a height and is unresponsive. Somebody is choking and now has become unresponsive. And there's heart attack or lung QT syndrome or severe asthmatic attack, and the individual is no longer responding to you, or there is unknown arrhythmia, maybe ventricular fibrillation, and the person is now in asystole, not responding to you. So in all these cases, we need advanced cardiac life support. There are so many conditions that are reversible that could lead to this. Hypovolemia, low volume, maybe excessive loss of muscle bleeding or vomiting or diarrhea. Apausia, when there's no enough ability to breathe properly. Hydrogen ion in excess or acidosis in any form. Hyperkalemia, when you run the value and the EKG and it's very high or very low, like hypokalemia. Hypothermia in wintertime or frostbite, or at any time the temperature is excessively low. Trauma of any sort, like fall, road traffic accident, leading to many possible troubles like bleeding, tension pneumothorax, cardiac tamponade, and the rest. And of course, tension pneumothorax on its own is reversible when you decompress, putting your needle at the right place, and then the air is gushing out. Toxins, chemicals of all many types, medications or street drugs, and of course pulmonary embolism and cardiac tamponade. Cardiac tamponade because the heart is like encaged or arrested. It's not allowed to freely expand and contract, so it's not pumping blood properly. Okay, the first step is whatever the cause or causes of this trouble could be, the individual is now unconscious, or there is a sudden cardiac arrest by assumption. So it is required that before ACLS, you must have had basic life support training. First thing to do is to shout for help or call code blue if this is in the hospital. Once that is done, you activate the emergency response, call 911 if not in the hospital. Make sure the environment is safe for yourself and the victim. For example, if this is along the road, it is not wise to start doing resuscitation or CPR without taking the victim across the main road. If not, you could be killed and the victim may not come back again. Tap this person, yell hello. If you know the name, call the name. If no response, then check the airway and remove any foreign body. Palpate the carotid pulse. If you can't pick pulse, start CPR immediately. Do not waste time and don't let anybody distract you. The assistance should go for automated external defibrillator if you can lay your hands upon anyone, and another to start ambu bagging or give oxygen as the case may be. You should attach the cardiac monitor right now or the defibrillator. If you call the 911, if this is not a hospital setting, the 911 people could be helping you along while you're on phone with them. So the first step is call code blue if in hospital, shout for help if it's not, call 911, make sure you are safe, make sure the victim is safe, tap this person, yell the name if you know, and start your CPR. Second step is to continue the CPR. We're going to talk about CPR all along here because that is the main thing. You're going to push hard with the heel of your palm on your dominant hand while the non-dominant hand is on top. Push hard equal to 2 inches and very fast. You are going to go for 30 compressions to 2 breaths. Allow complete chest recoil and minimize interruptions. Change or swap with someone else every 2 minutes so that you will not become tired. Intubate if you make that determination. Get quantitative waveform capnography, and if PTCO2 is less than 10 millimeters of mercury, improve the CPR. If the systolic pressure is less than 20 millimeters of mercury, improve the CPR quality. The center of it now is CPR. The third thing to do is now attach your automated external defibrillator. And that will prompt to tell you that the rhythm is shockable or not shockable. If it is shockable, you might be dealing with possible ventricular tachycardia or ventricular fibrillation. And if that is the case, give the shock. But make sure you send everybody away. Even the automated external defibrillator will indicate that. If it is monophasic, give 360 joules. If it is biphasic, then start gradually from 120 joules, or some people will start with 200 joules, and you increase with time. If you don't know the energy level, use the maximum available. Consider higher doses as you shock subsequently. 4 to 7 steps will be essentially that you continue CPR for 2 minutes and make sure you have 30 compressions to 2 ventilation. And you instruct someone to get IV line access for you, or if that is not possible, get intraosseous if no IV line. You check again for shockable rhythm and shock as is appropriate. Continue CPR for the next 2 minutes again. Do 30 compressions to 2 ventilation. At this time, you can give your medication, epinephrine, intravenously because the IV line is already secured, or intraosseous if no IV line is available. You can give your intravenous epinephrine as 1 milligram every 3 to 5 minutes, but you have to use the one with dilution of 10,000. You check your PTCO2 with capnography and consider endotracheal intubation in this individual. Again, you are going to check your rhythm with external defibrillator and shock as it is appropriate. The 8th and 9th steps will be essentially that you continue your CPR again. So it is CPR, ventilation, and compressions. Avoid excess ventilation. Give amiodarone this time, intravenously or intraosseous, and at level of 300 milligram bolus. The second dose should be half of that at 150 milligram. Look out for any reversible causes and treat appropriately. Check the introductory part of my presentation here to know those possible reversible causes. Then you check your rhythm again. If not shockable, then you have to treat as asystole or pulseless electrical activity. And in pulseless electrical activity, you give your CPR for 2 minutes, swap CPR compressions, 30 compressions to 2 ventilations. You give your epinephrine, and to trigger intubation, apply your capnography, but you are not going to shock. You check the rhythm again. If not shockable, then you don't shock. You just continue CPR. Look for reversible causes and treat immediately. The advanced airway could be supraglottic advanced airway, endotracheal intubation. Put your waveform capnography to confirm and monitor the endotracheal tube once placed. You are going to maintain 8 to 10 breaths per minute with continuous chest compressions. But if it is shockable, shock. Then administer your medications as in 5th step, 6th step, and 7th step as previously described. And the 12th step, which is the last step, if the rhythm is not shockable, I'm going to check for signs of return of spontaneous circulation. If you're able to get that, fine. You're going to start post-cardiac arrest. But if there is no return of spontaneous circulation, then you go back to steps 10 and 11 as described before. In conclusion, decide on the continuation of CPR or not. In other words, with your group, take the decision to continue CPR if you have not yet revived this individual, or you discontinue CPR, but that decision will be taken with your entire team, and of course, you carry the family members of the victim along. Wishing all the sick people well. Kindly subscribe to my channel. I'm likely going to make basic life support presentation very soon as well. You can be on the lookout for that. Thanks, I appreciate it.